Cerebrum 2, Unit 3. Basal ganglia. On this diagram, the red arrow points to the basal ganglia, which is labeled in green color. We are going to talk about clinical considerations in patients with basal ganglia disorder. The most commonly seen disorders affecting the basal ganglia include Parkinson's disease and Huntington chorea. Other diseases include Wilson disease, tardive dyskinesia, and dystonia. All of the above medical diagnoses involve impairments in muscle tone, movement coordination, motor control, and postural stability. The patients are likely to present extraneous movement. And the movement disorders may range from hypokinetic to hyperkinetic. Hypokinetic means there's too little movement. So there is an excessive inhibition, which results in hypokinetic disorders. This is seen in patients with Parkinson's disease. Now, hyperkinetic means too much movement. There is inadequate inhibition, which results in hyperkinetic disorders. And this is seen in patients with Huntington's disease. Let's first talk about Parkinson's disease. In Parkinson's disease, we can observe degeneration of substantia nigra, specifically the part of substantia nigra called pars compacta. In patients with Parkinson's disease, there are lack of dopamine. It is a type of neurotransmitter. When there are symptoms, 80% of dopamine-producing cells in substantia nigra died. The patients with Parkinson's disease usually present with tremor, rigidity, bradykinesia, postural instability, and gait changes. Let's first look at tremor. Tremor is the initial symptom in 70% of Parkinson's disease patients. This type of tremor usually begins in one hand. The tremor observed in Parkinson's disease is present at rest, so it is called resting tremor. Resting tremor usually disappears or decreases with movement, and it has a regular rhythm of about 4 to 7 beats per second. Some people with Parkinson's disease may have a postural tremor. Postural tremor is another tremor type called action tremor. On this slide, the table shows different types of tremor. Basically, tremor can be classified as action tremor or resting tremor. Action tremor occurs with voluntary contraction of muscle, while resting tremor occurs when the person is at rest. There are 3 types of action tremor: postural, kinetic, and intention. Postural tremor occurs when a body part is voluntarily maintained against gravity. Kinetic tremor occurs with any form of voluntary movement, while intention tremor is a type of kinetic tremor. It is amplified as the target is reached. The presence of intention tremor implies that there is an injury in the cerebellum or its pathways. In patients with Parkinson's disease, majority of the patients present with resting tremor, but some of the patients with Parkinson's disease may have postural tremor. The second important characteristic of Parkinson's disease is rigidity. The rigidity is the increased resistance to passive movement, regardless of speed of movement. An increased resistance to movement throughout the entire range in both directions, without the classic characteristic of spasticity. The biggest difference between rigidity and spasticity is that in rigidity, the muscle tone doesn't change with the speed of passive movement, while in spasticity, the muscle tone will increase if the speed of passive movement is increased, and the spasticity will be lower if the speed of passive range of motion is slow. Rigidity might increase energy expenditure. Rigidity may be related to feelings of fatigue, especially post-exercise fatigue. Bradykinesia and akinesia. Bradykinesia is a decrease in motion, while akinesia means lack of motion. Both bradykinesia and akinesia are characterized by an inability to initiate and perform purposeful movements. And all aspects of movements are affected, including initiation, alteration in direction, and the ability to stop a movement once it's begun. Another feature of Parkinson's disease is postural instability. Postural instability is rare in early years, and the contributing factors for postural instability include rigidity, weakness, decreased muscle torque, and loss of range of motion. Postural instability is a serious problem because it can lead to increased episodes of falling. More than 2/3 of all patients with Parkinson's disease fall. Gait hypokinesia affects almost every Parkinson's disease patient, and the severity increases as the disease progresses. The fundamental deficit in gait hypokinesia affects the step length regulation. Shorter step length is related to smaller ground clearance. The usual height between the ground and the foot is 1 to 1.3 centimeter. However, in patients with Parkinson's disease, the distance between the floor and the foot is less than 0.8 centimeter. Therefore, the patients with Parkinson's disease have greater risk of tripping over, and they are more likely to fall. There are other non-motor symptoms in patients with Parkinson's disease, such as loss of sense of smell, constipation, orthostatic hypotension, sleep disorder, and hallucinations. The other important disorder affecting basal ganglia is Huntington's disease. In Huntington's disease, we can observe degeneration of striatum, a part of basal ganglia. Since there is an inadequate inhibition, the movement becomes hyperkinetic. So the movements are described as chorea, which means spontaneous irregular movements, balismus, which means continuous choreatic motions, and dystonia. Chorea is an abnormal involuntary movement disorder. We can observe brief, irregular contractions that are not repetitive or rhythmic, but appear to flow from one muscle to the next. Chorea is caused by overactivity of the neurotransmitter dopamine in the areas of the brain that control movement, that is basal ganglia.